Good evening. I'm Charlie Wyckoff, retina specialist from Houston, Texas. Great to be here with two friends tonight, Carmen Puliafito, retina specialist in California, and then our guest of honor, Paul Hahn. Paul Hahn really needs no introduction. He is at NJ Retina, has been around, a leader, a mover, and a shaker in retina for a long time. Most recently, maybe known on podium as leading the PAT survey. No easy feat, so he certainly has his hands in the mix and understands deeply what physicians are doing on the block. So Paul gave a fascinating talk at ASRS all about the two new agents that we have from an FDA approval perspective to treat geographic atrophy. And we're happy to take a deep dive with Paul into that data tonight. Paul, thanks for coming on. Great to be here with you.
Yeah, Charlie, Carmen, it's really my pleasure to be here, and thank you for the kind introduction.
Yeah, so Paul, tell us the background of the study, the setup for the study, the methods, and then we'll pause and look at what you actually found.
Yeah, of course. So this is 2023 really represents a pivotal year for us as retina specialists. We now have a treatment for the first time ever for geographic atrophy, a really blinding condition. And not only do we have one treatment, but we now have two treatments. So as we all know, pegcetacoplan or Syfovre was FDA approved in February of this year. And about 6 months later, we saw the approval just a month ago of Izervay or avacincaptad pegol. So now as retina specialists, we have not one, but two different treatments for a condition where we couldn't previously treat patients. And so how do we decide which of these drugs to use? There are obviously a lot of factors which will go into that decision-making process, but it would be very tempting to try to compare the relative efficacies through clinical trial analysis. That's often what we might consider doing is just looking at the top line data and trying to compare those numbers, but it's not the right way to do things. We know, just generally speaking, that you can't just look at top line data from clinical trials and look at those and compare the numbers. But there is a proper way to do this, and that's what we did here. So if we step back a little bit, and if we review the basic study designs of the pegcetacoplan trials and the avacincaptad pegol trials, then I think that'll be important to frame our understanding of how this analysis was done. So first of all, pegcetacoplan was studied in two different phase 3 trials, OAKS and Derby. And these trials looked broadly at patients with geographic atrophy, including patients with non-subfoveal geographic atrophy, as well as patients with subfoveal geographic atrophy. And they looked at two different dosing, monthly dosing and every other month dosing, whereas avacincaptad pegol, or now Izervay, was studied in a single true phase 3 trial called GATHER2. There was another study called GATHER1, but that was a mixed phase 2 and phase 3 study. So the only true phase 3 study was GATHER2, and GATHER2 looked only at non-subfoveal lesions, only with monthly dosing. And so if we look at the top line data between the two trials, GATHER2 saw a 17% reduction in GA growth at 1 year. And if we look in OAKS and Derby combined, we saw a 16% reduction, but this combined both non-subfoveal and subfoveal lesions as opposed to the non-subfoveal lesions only as in GATHER2. And that matters because we found that non-subfoveal lesions tend to progress faster, and therefore your efficacy rates can be better or greater if you only limit your population to non-subfoveal lesions. And so if we look at a pre-specified endpoint in OAKS and Derby and only look at the non-subfoveal lesions in OAKS and Derby, we'll see a 26% reduction combined in OAKS and Derby, again, compared to the 17% seen in GATHER2. So looking at those two non-subfoveal populations, as I mentioned before, it might be tempting to just look at that and say, oh, well, Syfovre is reduces by 26% versus Izervay, which reduces by 17%, and therefore Syfovre is a superior drug. But of course, as I mentioned earlier, you can't just compare top-line data. So this approach that we did is called an anchored, matched, adjusted, indirect comparison, in which you try to match the populations in the individual trials to compare the outcomes side by side. And so to do this, you limit the inclusion and exclusion criteria from the more restrictive trial to the less restrictive trial. So in the GATHER2 study, they only looked at non-subfoveal lesions. They only looked at a certain range of vision, worse than 20/25. They excluded fellow ICNV, and et cetera, whereas OAKS and Derby were more restrictive. So in this study performed with Apellis, we had access to the individual patient level data from the Oaks and Derby trials, and we took those patients and filtered out anyone who didn't meet the inclusion and exclusion criteria published or reported for GATHER2. So we only looked at non-subfoveal lesions. We excluded fellow IC and V as in GATHER2. We restricted to the same level of vision as in GATHER2. And once we had a matched population, we then sought to balance that population by performing propensity score weighting to match key characteristics such as age, vision, IOP, and of course geographic atrophy characteristics such as size, multifocality, laterality, and so forth. And so now with this matched and balanced population, we can then go and try to compare the outcomes from the different trials.
Okay, got it. So you had access to the granular data of Derby and Oaks, which is more of the inclusive trial versus the more sort of restrictive trial, the GATHER2 study. Is it a limitation that we don't have such granular data for the patients on GATHER2? Or because it's more restrictive, that is not a necessity to achieve sort of statistical balance here?
In an ideal world, I think it would be great to have granular data from both trials, from all the trials. And if we did, then we can really deep dive into these and try to analyze all the differences and try to create as matched of a population as possible. In this study performed with Apellis, we only had patient level data from Apellis, and so we can make do from that regard. But as we think about not just applications of this methodology to Syfovre versus Izervay, but really all different drugs, I think it would be great if we did have access to the both study data sets.
Okay, two more questions before the results. So the first one is, are we fairly confident, or how confident are we here, that the patients enrolled in GATHER2 are phenotypically, right, anatomically the same as what we're defining as non-subfoveal patients in the Oaks and Derby data set? Are we pretty sure that those are the same, or could there be differences there?
I think our understanding of geographic atrophy is so rudimentary, and everything that we call geographic atrophy, there's probably a large spectrum of what that atrophy actually is. And so I think the phenotypes of all these patients is probably variable, and I can't imagine that there's going to be consistency. Certainly, I think we've seen differences between Oaks and Derby, for example, and those might correspond to differences in unforeseen baseline characteristics that were identified, or perhaps different phenotypic differences that we just don't have the understanding of.
Got it. And then one more question about the method. So you pointed it out very clearly, supported here by Apellis, the presentation, the analysis that you have. What does that introduce? What sort of biases does that introduce, that it's not supported by one company, but supported by the other company? How does that potentially influence the outcomes?
I think anytime a study is supported by a company, I think there's always going to be the potential for bias as we look into these things. All of our, as we tried to match the characteristics and, balance the populations, all of our characteristics were decided a priori to try to minimize any bias and so forth. We incorporated retina specialists for objective opinions and objective insights as well. But, I think for all these types of studies, there's always going to be the potential for bias. And, I think, that has to be taken with consideration.
Great. Thank you. Good. Tell us what you found.
So after we matched and balanced those populations, we compared the different studies. And so as I mentioned earlier, the Oaks and Derby trials looked at Syfovre given either every month or every other month. So we compared monthly dosing with Syfovre to monthly dosing with Izervay, or avacincaptad pegol. And we also compared every other month Syfovre dosing to monthly Izervay dosing. And so I'll talk about each of those different comparisons separately. So our first comparison was apples to apples, monthly versus monthly of each of the two drugs. And if we look at the comparison of Oaks and Derby combined versus GATHER2, we found a 30% greater reduction in geographic atrophy at 1 year, favoring Syfovre or pegcetacoplan compared to Izervay or avacincaptad pegol. This broke down to a 37% greater reduction seen in the Oaks comparison but a 12%, and those differences were statistically significant, both the combined Oaks and Derby of 30% and the Oaks alone of 37%. In Derby, where the 1-year results were a little bit less robust, we saw a 12% greater reduction, also favoring monthly Syfovre compared to monthly Izervay, but this difference was not statistically significant. But again, the overall Oaks versus Derby comparison was a statistically significant greater reduction of 30% favoring Syfovre. If we looked at every other month dosing, so less frequent dosing with Syfovre compared to monthly Izervay dosing, and I'll remind you that Izervay was not tested every other month, then what we found were numerically greater trends towards greater reduction favoring Syfovre, but none of these in either Oaks or Derby or combined Oaks and Derby were statistically significant. So our conclusion for that was that the every other month dosing was similar or equivalent to monthly dosing with Izervay, but that the monthly dosing with Syfovre appeared to be superior to that of monthly dosing with Izervay.
Fascinating. So what's your takeaway from this?
I think everyone's takeaway should be, I think as people take away this type of data, obviously the implication is how are we going to incorporate those drugs into our practice? And, I think there are a lot of factors, as I mentioned earlier, that go into that. One, of course, is the relative efficacy. And I think this gives, some piece of the puzzle that perhaps, according to this analysis, we see a greater efficacy with Syfovre compared to Izervay. Now, all the caveats, all the kind of limitations and the biases and so forth, part of which we discussed need to be taken into account, and retina specialists should factor that in. But there are other things that play into as well. So we have 6 months more clinical experience with Syfovre, and I think many of us have gotten a sense of how to administer it and how it works. We've also seen some recent side effects with Syfovre, and I think that may factor into people's decision-making processes into which drug to use. We, of course, don't have that same type of utilization history or real-world history with Izervay, and I think that needs to factor in as well. We also have longer-term data from a clinical trial standpoint with Syfovre, and there's been a lot of exciting data also presented at ASRS, looking, for example, at the Gale extension study with 30-month data suggesting that with time, we see a cumulative increase in efficacy with, at the most recent 6-month time point up to 30 months, up to a 45% reduction in GA growth in non-subfoveal lesions. So very exciting things that we see with Syfovre. Again, we have a longer clinical trial history and a longer real-world history. And how Izervay kind of competes with that, I think remains to be seen. And as a retina specialist, I certainly kind of welcome learning about all the different good things that Izervay can provide in the setting of the benefits that Syfovre can provide as well.
Fascinating analysis. And then when we have additional data, for example, we're going to have 2-year data from avacincaptad probably in the next month or so, publicly available. Will we be able to do these analyses then, given that additional data, knowing that we already have additional data from Oaks and Derby?
Yeah, I think we can extend that analysis to the 2-year time point. I think that should be something that would be of great interest.
Fascinating. And then one other question more broadly, interesting approach, and you can imagine a lot of settings where this would be interesting. For example, to compare faricimab to Eylea, to Lucentis, to Avastin. Have we seen the same statistical approach been used in anything else in retina so far?
As far as I'm aware, not in a meaningful way. It does require kind of certain characteristics for the trials to be able to be applied to the other trial.
Yeah.
But I am aware of similar types of investigations being pursued for some of these new medications. And so I don't want to give too much away, but I invite you and the retina community to stay tuned because I think something's going to become available.
Exciting. Great work, Paul. It's always exciting to see a new sort of approach to analyzing the data that we have brought out into the field. There's always controversy whenever you compare 2 new drugs. So I genuinely applaud you, Paul, for being willing to do this and stand up and go through this. It's important. It's important that we as retina specialists don't shy away from comparisons when our patients truly want to know what is the right choice for me. And you're right. it's always a balance of safety, efficacy, access, burden. I mean, all this stuff is quite relevant, but we need more data to guide that, and this is really helpful. Thank you, Paul.
Thanks, Charlie. Yep.
Thank you, Paul.
Yeah, thanks, Carmen. It was really a pleasure to be here and to talk to you today, and thanks for the opportunity.